Are we ready?
Okay. Yeah, we're up.
All right, good morning, everyone, and welcome to this meeting of the Primary Care Access Delivery and Payment Task Force. It's great to see everyone this morning. I'm David Seltz. I'm the Executive Director of the Health Policy Commission, and I'm honored to co-chair this task force. This is the 8th meeting of the Primary Care Task Force and its requisite work groups. And I think our second meeting fully in person all together. It's great to see everyone back together again. And I'm looking forward to a great meeting here today and a great conversation and discussion. Before we dive into today's agenda, I'm really pleased to invite my co-chair and the Secretary of Health and Human Services to provide some opening remarks.
Thank you, David, and thank you for everybody who is here in person, and thank you for those of you who are joining us online. As you well know, the primary care crisis is ever deepening as we keep meeting. I've had some spirited conversations with some of you over the past few weeks. I'm hoping that the discussion today will be equally rich, and I'm looking forward to hearing your opinion. And please remember that you were gathered here for your expertise and your ability to sort of reflect your lived experience. So we really hope to get some good comments going as we go through this. As painful, whenever it gets painful, I just think, oh, it's Chair Lon and Chair Friedman who are imposing this pain on me by writing the statute. So I'm excited for the meeting today, and David, take it away.
Great. Thank you, Mr. Secretary. And as you can see on the slide, the full representation of the 25-member task force, an incredible group of experts. And it's been a real pleasure to get to know all of you over the last few months and to be able to collaborate with you and hear all of your great input and expertise. And I also want to recognize Chair Friedman and Chair Lon. Thank you for your leadership on these topics and for your foresight and wisdom in putting this task force together. You gave us a very ambitious list of tasks and deliverables. We have been hard at work to try to meet that schedule. And I hope today that we might be able to put a green check mark next to deliverable number 1. So that is going to be our first agenda item. And that deliverable number 1 is around defining primary care service codes and providers. And we have a final proposal for discussion today that incorporates feedback that was submitted by all of the task force members over the summer. We're then going to discuss some next steps for deliverable number 2, which is to develop a standardized set of data and reporting requirements for private and public payers, providers, and provider organizations before diving into a discussion on proposals for deliverable number 3, which is to establish a primary care spending target. While we want to stay on track on these deliverables as laid out in our statute, I think it's also important to recognize that we have so many thought leaders here in this room, people who have spent their entire careers thinking about primary care and how we could make primary care better in the Commonwealth. And so we're actually going to spend the bulk of our time here today having a little bit more of an open conversation and an open discussion to hear from you about what we should set as our vision for primary care in Massachusetts. What should primary care be, and what are the strategies needed to realize that vision? So I'm really looking forward to that open conversation and discussion with you all later today in this meeting. Before we dive into the content of the meeting, of course, we do need to approve the minutes from the last primary care task force meeting on July 22nd. We can do this in person with just a call of the yeas and nays. So I will call first for a motion to pass the minutes. A second. Thank you. I call the yeas.
Aye.
Any nays? Yeas have it. The minutes are passed. Thank you so much. Any abstentions? One abstention. Thank you, Barbara. Thank you for letting me do that. That was fun. Oh, yeah. I'm getting used to the senator. Thank you. You'll give me some notes. All right. So we're going to dive right into our first agenda item, which is statutory deliverable number one, proposal of our final proposal for defining primary care services, codes, and providers. So ahead of this meeting, we shared the final recommendations for the task force final deliverable to define primary care services, codes, and providers. We shared this with you in August and asked for your feedback at that time. We did receive feedback from a number of members and did our best to incorporate all of your feedback at that time. We've had a number of discussions among this group as well as at the work group level on these recommendations. So thank you for all of your input at the July 10th meeting of the Data and Research Work Group, at the July 22nd Primary Care Task Force meeting, and of course, via email to us. These final recommendations incorporate a lot of your feedback, and I'll highlight that as we go through these. I believe these recommendations reflect the consensus that we've developed, and our goal today is to finalize and post these deliverables to the HPC's website under the Primary Care Task Force website. And if any task force members would like to provide additional comments that are not currently incorporated in this final deliverable, we'll have an opportunity to share those and have those be reflected on the record. So first, as a reminder to all, the task force's overall recommendation is for the state to rely on CHIA's technical expertise and experience to continue its highly credible and robust process for defining and measuring primary care spending. The current CHIA methodology will be attached to this deliverable. It's not currently in the version that you have before you, but will be, and will be posted alongside the text that was circulated on the website. Since we last reviewed the proposal, we did include additional text in the introduction that highlighted specifically some values around primary care and incorporated some text highlighting the 4 C's of primary care: first contact care, continuity of care, comprehensive care, and coordination of care. We added a recommendation for CHIA to include a comparison of its methodology to alternative approaches to enhance its transparency of how it's going about making its methodology. And we also specified a timeline for CHIA to finalize its data specifications and require data collection within 6 months of the primary care legislation's effective date. We also specifically added, per a suggestion from one of the task force members, community health centers and technical experts into the healthcare advisory group. We also added a footnote into the CHIA's annual reporting recommendations that if CHIA were to change its methodologies, that they would be sure to explain the changes and make appropriate caveats explaining how those changes may make longitudinal analysis comparisons. Finally, we added some more detailed language to the additional policy consideration section to provide additional clarity about those recommendations. And finally, I just want to remind task force members and the public that these recommendations do align with the existing primary care reform bills that are before the legislature. Those primary care reform bills do also direct CHIA to consider recommendations from the primary care task force when defining primary care expenditures and generally defer to CHIA to define primary care expenditures. So at this point, I am wanting to just open the floor for any discussion, any comments, any questions that members have on this first deliverable.
Just a brief comment. I want to publicly thank Director Peters and CHIA for their great work that we were able to leverage to positive effect here. I think the running start that we have is not just a running start, it's really a leap and a bound. So thank you to Lauren and her whole team.
Dr. Freeberg? Just make sure the mic is on.
Is it on? Is it on?
No, press it again.
We'll try one more time.
Yep.
There we go. Awesome. Yeah, I wanted to say thanks for being so responsive to comments to HPC in the drafting of this. I think it's very well written. I don't have any additional changes to suggest. I just maybe note for the record, and that doesn't necessarily need to be in the deliverable, that the caution about longitudinal trending of primary care spending over time, as the definition may change, that it's good to always have that caution be there so people don't mistakenly think that spending is going up when it really like half of that is due to a change in definition. One thing I would encourage HPC and CHIA to consider, in addition to that, is back calculating all previous years using the new method. That actually will allow longitudinal comparison over time.
Great, thank you, and I agree. Renee?
Look, so my question is this, this is about the advisory board body. One of the things that they're supposed to do is basically sort of evaluate the impact. And I think it is curious to me that I would prefer if the health fans were not a voting member and they may be an attending member, because we're actually judging how well they're spending. And why should they be voting on how well they're spending? It's also a concern to me that in my private conversations with wonderful people who work at these health plans, one of the things that they're always really clear about is they have no investment in making long-term changes since they have this person only for 3 to 5 years. And that's concerning to me. So if they're on the advisory board, I think it'd be more judicious to not have the person you're judging actually voting. I think it might be better if they were just advisors to the advisory board and provide information. Because what I fear is that we're going to run into a situation like we did with the RUC. And on the RUC, which is the folks that set the prices that are paid, one of the things that happened was it was originally designed to help primary care. But what happened was the membership of the RUC committee became more and more specialists. And you know what happened? The specialists determined that they actually needed more money than the primary care people. And we got in the situation we are now. So what I'm concerned about is that we put people on who are voting, who have no interest in long-term and are being directly judged by the information that CHIA is delivering. So it would be my preference that they were advisors to the advisory board as opposed to voting members. It's just a thought.
Thank you, Dr. Critchlow. I just would note, I think in the text as currently written, I don't think that we specify whether these are voting members or not voting members. I think it is,
That's why I mentioned it.
it is
So we
kind of
can-
ambiguous,
We can
so.
get ahead of it.
But I think we can note your point there. Thank you. Senator, do you want to say something?
Yeah, just to respond to that, I think that's actually a really good point. I would also say the same thing for health systems. I mean, if this is a primary care advisory board, I think it should be advised by primary care and others who are directly, so I think you raise a really good point if there is, but I would include health systems in that.
Barbara?
Thank you. Yeah, I see this as the system holding the system accountable. And one way to do that is add consumers to this, because that way there's people who are getting the services are holding everybody accountable.
Christina?
I love that, Barbara. I would also be in favor of adding consumers, and I want to echo Dr. Crutchlow and Chair Friedman in amending the language to remove health plans and health systems. I also would offer a friendly amendment for what it's worth to just modify community health centers, which in Massachusetts is a broad term, to federally qualified health centers, so for specificity.
Hi, I just wanted to add, related to that, I think some of our advocacy groups that really advocate on behalf of patients aren't listed here, and our providers, are MMS, nurse practitioners, AAFP, AAP, so I didn't really see them in that list, but I think that was just sort of a terminology question. And related to that and to our task force, later on, there's a question about the definition of primary care as it applies to OBGYN. And I would just note that they're not here at the table here. They're not on that list. And I'm not sure exactly where they fit in with the primary care, but I just point that out as a difference.
So hi, we would obviously take exception to being excluded from the advisory panel. I think that if you want community buy-in, you want stakeholder buy-in, the plans are an integral part of this conversation, and the plans I represent are doing both public and commercial programs. So we rely very heavily on primary care, particularly for the underserved, those in Medicaid, SCO, and OneCare. I think you want them at the table. I think you want them participating. And so those are my comments.
I guess I would echo the need to have consumers on there. I would be a little more specific, though. I think sometimes when we look at patients and consumers, we forget about actual premium payers. And I think it's very important that those that are paying the premiums, and I think as the commissioner knows, we're looking at what 11 to 13% increases for small businesses and their employees next year. Any discussion we have going forward on healthcare access and costs, we need real premium payers at the table.
Barbara?
Nope.
One of the things we have to remember is that probably 70% of primary care is now employed in this state by systems. And so when we talk about excluding systems, I think we need to be clear that we want to have representation from those who are in private practice, where the pressures are very different than those who are employed, but also recognize that many of us in this room may be employed by a system, but we're not representing the system. So we're going to have to figure that out, because you can't exclude those of us who may work for systems, present company included. I certainly don't represent them when I'm sitting here. But we need to be sure that we do both, that the private practitioners are also represented. Thank you.
Dr. Freeberg? Oh, excuse.
Yes, thank you. This is could be construed as a detail, but I feel like it's important to slightly edit the wording in the section on annual reporting. I think here, everyone would agree that that's what we meant when I say what I'm about to, but a month or a year from now, people not in the room might wonder what we meant or assume we meant something different. It says the legislature should require CHIA to report annually on primary care spending. I would flip those words a bit to say to report annually on spending on primary care, because I think that's what we're mostly after, rather than what I, as a primary care physician, spend in my office. That's interesting too, or spend on healthcare for my patients. But I think that I'm sure I'd want it to be very clear to people not in the room with us.
Good catch.
Thank you. Thank you. And then that's high praise. Thank you. And on the second part of that sentence, it says report annually on primary spending in Massachusetts, including as a share of total statewide expenditures. That's good. That's interesting. We might mean a total as a share of total statewide healthcare expenditures. I think we do mean that. I mean, I feel like that's what, when I look at CHIA, that's what I see. And I think that's valuable to either add the word healthcare between statewide and expenditures, or add the whole phrase in so that we get that too.
Yeah.
Thank you.
I think Dr. Mellon, I can say great edits. We'll make those changes.
Thank you.
I just want to be clear that we are talking about the definition of primary care here. We're not talking about how much, we're not talking about yet whether, we're spending, or this is really about how we capture what we're spending. But what we're really doing here is defining what it means to be primary care. And I guess, so I hear this, the premium payers should be at the table but we're not there yet. We're just trying to define what it means to deliver primary care. And so, to your comment, Dr. Spivak, what I mean by the system is the system shouldn't represent what it means to deliver primary care. The primary care doc should deliver, or the people who are practicing should be the definition of what it means to be primary care. Now, do we need independent analysis of that? Absolutely, right? Do we need to verify that, yes, this is a primary care, this is part of primary care? Absolutely. But this isn't about yet whether we want to spend the money on that or what we're willing to do. It's really just, can we just get a good definition and understanding of what we should be tracking? So I just want to say that, and I think to the point that was raised by others, that's, I think, why there's a kind of question about health systems, which have a very vested interest, and insurers, which have a very vested interest in the outcomes of what it costs to provide primary care. So I want to make that separation here. They are very important. It matters a lot, but right now we can't even define what it means in a robust way that will help us track it. So that's fine.
Yeah, thank you, Senator. And I, as I'm reviewing this language and looking at this in real time, and I think always a danger to try to make edits in real time. But as I'm thinking about what I think the core intent of what this was about was really about trying to think about who do we want to help advise CHIA on the ongoing technical work of defining, updating the codes. Are there changes that need to happen in the kind of technical specifications of the definition of primary care? And so I think there is a larger question of a quote unquote primary advisory group that is going to be thinking about the primary care spending target and accountability to the primary care spending target, and advising on payment methodologies. That is, I think we haven't gotten to that yet. And that is a place where, premium payers, consumers, like that is a place I think very likely they should be in. I don't know that what we need for the technical advice here for CHIA may be different from that larger, more policy focused body. So if you have the language in front of you on this one, under the new primary care advisory group, maybe to the legislature should establish an ongoing primary care technical advisory body to advise, cross off that sentence and just say to advise or to provide technical input on CHIA's data specifications. And that way it's really cabined to what we're trying to do with this deliverable. Do people see what I tracked there?
Very much, sir. Thank you.
Dr. Freeberg?
Yeah, I think it's a little dangerous to start trying to exclude folks from this kind of a group on the basis of real or perceived conflict of interest. We can get very selective about that. Everybody who's on the receiving end of a primary care payment has an automatic, very personal interest in spending targets and the definitions that underlie those spending targets. Those things are, inextricably linked. So I think it's fine to be talking about spending targets in the context of the definitions that they rest on. I also say there are people who are going to wear multiple hats here. We may have people working at health plans who are also providers, who are also technical experts in measurement spending. To blackball a group would be very counter to the success of this group.
Dr.
Thanks very much and appreciate my classmate Mark Friedberg's comments. I would offer a slightly different point of view, which is that whatever set of arrangements and constituencies have gotten us into this crisis should not be replicated in the arrangements that we want to have going forward. That is, as Dr. Critchlow mentioned, if you have a certain set of actors at the table, you're going to get a certain result. And we've gotten that result now for the past quarter century in Massachusetts. And I'm not so interested in proceeding with the same arrangements. And so when arrangements change, some people gain and some people may lose. And that is how things change in a democracy, as long as we are all represented. And so I am, this idea, I don't think blackballing is not a term that ever came to mind. It was, what is the relative power of any given constituency around this table and in the Commonwealth? And certainly patients are not even at this table, even though we all quote, may be patients. Believe me, if you're a patient, you have a very different set of expectations for what we should be doing here today. So the arrangements we have going forward, if they are not different from what we have now, we should expect failure, just as Einstein said many, many years ago. So I think we should recognize that if there's not a delta in what we eventually come to, then we should be wary of any constructive results.
Dr. Altman, and then I'll come back to you, Mike.
Thanks for your comments, Steve. I agree with your comments, and I also would add that Dr. Critchlow, if I recall correctly what she said, she was not calling for the removal of these people from the table, but kind of echoing what Steve is saying, giving the appropriate amount of power to do something differently with that differential of power to create a different result. Now, I have a question for the group. I sort of hear you saying, David and Chair Friedman, that that this deliverable number one is the purpose of this deliverable to assign which roles would be on this advisory body, or are you wishing for the assignment of which roles and what we're talking about now to not be part of this deliverable number one? Because if it's not part of deliverable one, then this conversation is moot.
I think I'm suggesting maybe to focus on deliverable number one. Can we just think about the advising Chia on the technical aspects? That's right. And maybe tabling the larger conversation of the policymaking advisement to another deliverable.
I think we would agree that the roles of people on that advisory body is a very important conversation.
Absolutely.
But you're suggesting that that's not this conversation.
I am suggesting that, yes.
Yeah, this is getting really confusing. what I was suggesting is those people who are very specifically about the definition of primary care and the understanding of what it means what that entails are the people that will provide the technical expertise, not the greater primary care advisory board is it's different. It's more, it's got different deliverables or tasks. So I think we're just trying to define who should be on this technical advisory piece. And I think the people who directly deliver and maybe receive, I'm talking about money here, we're just talking about what the definition is. What does it mean to deliver primary care? Those are the people that should be on the technical group. So there's two things. Yes, there's members here, there's members there,
So you're suggesting language in this deliverable to speak to that. I would support that.
I think it's important to remember that we're providing guidance for the definitions towards what will end up becoming legislation. And so to the extent that we echo philosophy behind the membership of the group is really important to echo what Senator Friedman just said and Wayne Altman. I would actually strongly suggest that to the extent that this particular paragraph gets into data specs, there will need to be technical experts rooted in the field who do this work. I can't tell you how many calls happen each month with CHIA between health plans and CHIA or health systems and CHIA. And so I'm not arguing for or against it. It will happen one way or the other. And CHIA will have to have that reliance on that expertise. So it's almost like a moot point.
Laura,
Yeah, I just.
can you use a microphone, please?
Just noticing the language here, around the annual reporting, and there's a few other references, just making sure we're using provider neutral language. I see physician here as opposed to provider, particularly managing physician organization. And there are a few other references that I can point out.
A lot of folks prefer clinician to provider, if that's acceptable.
That's whatever works.
Please.
Thank you. We'll make that change. So again, I guess I just to suggest a change for this deliverable, recognizing that there is a larger conversation about a potential policymaking advisory group for the larger future of some of the big pieces of primary care that we want to talk about, but specific to this deliverable, specific to having some guidance of recommendation to the legislature about who CHIA should consult with in terms of their ongoing work of defining primary care on this annual basis. Again, on this particular bullet point, to repeat a suggestion of a change, calling this a new primary care technical advisory body. Legislature should establish an ongoing primary care technical advisory body to advise on technical input on CHIA's data specifications, et cetera. And delete the parts about primary care policy and rulemaking, and indicate that this is about advising CHIA on technical input.
That sounds good. It's a process question. Which deliverable will the policy, what you've removed out, does it go into deliverable? Are there 2 and 3? Are there more than 2 and 3?
Yeah, so just to show you this, I think to look at our list of deliverables here, and you have the slides in your packets as well. What I would propose is I do think 2, 3, and 4 kind of go together. Developing a standardized set of data reporting requirements for private and public payers and providers and provider organizations. We've started this conversation. To me, this is kind of, as I've said to some task force members, this is kind of the follow the money deliverable. How do we ensure, if we're making a recommendation about increasing spending in primary care, that spending is actually going to primary care, and have some way of, either through non-claims payments or through other payments, a way of assurances that, yes, as we're creating a spending target, that investment is actually going to increase, the investment in primary care. So that's kind of how I think about that specific deliverable. Establishing the primary care spending target is about that aspirational goal, about having a measurable target for where we want to shift and rebalance our healthcare system, and setting a target. We're going to talk a little bit more about that. And then proposing payment models is changing the way we pay, and changing the way we pay in order to be able to enable the change in how we want to change the delivery of care. So to me, all 3 of these go together, and as part of this recommendation and these deliverables, there will be some, state government entities that will have some role. And as part of that, I think there's going to need to be a primary care policy group that is going to need to have a role in, advising and having some, some way of interacting with government, in being able to provide expertise. So Christina, to your question, I would say that we're going to need to figure that out in combination with those three deliverables. Does that sound reasonable to this group?
So two comments. I'll get to that one as a second comment. I agree with what Mike said about technical knowledge being critically important in that body. I also think that Renee's suggestion of payers and hospitals not having a vote but being at the table is completely consistent with Mike's suggestion and provides that technical expertise at the table. And in terms of the advisory body for health policy and primary care policy, David, I think I agree with you, and I don't see why that needs to be two different groups. I think this primary care advisory body that we're talking about in deliverable number 1 can be the same advisory body that we're talking about in advising health policy, which is why I don't know that we need to remove that clause about advise on primary care policy and rulemaking. I don't see how this conversation necessitated the removal of that clause.
Having chaired QMAT, which is the quality measures
Yeah.
advisory something, I would completely disagree. The level of like discussion that happens in terms of technical questions, like Mark can tell you, we've argued about like, what does mammogram at 45 mean for like 3 hours? Like I think that like the level of technical detail would actually stop policy people from coming to the meeting. Like it would be so discouraging. So I think you really want
Two different bodies.
you really want two different than one that's purely technical. Sometimes it's like, what platform do you use and what are the statistical bandwidth that you're using for a particular, like it just gets like, I must say that Mark will say that he has seen me go to my happy place in those discussions. I like it gets just so deep. I really think that like you would really not enjoy it. So I would say we should have two, and you can even have like a technical group report to the larger group if you wanted something like that, right? But I don't think you'd want Laura Pellegrini and yourself and Christina like delving into which HLA B7 software platform you're going to be using.
Point taken.
Thank you for that, Secretary. And I think I agree with that too, just the point that you made. I think part of what we need to figure out is the relationship between these two groups. And I understand the need for these two different groups. And I'm glad that we had this conversation so that we all understand what the role is of them. But I do like the idea of figuring out what's the relationship, because I think maybe there should be some relationship between the broader policy group that helps inform the technical advisory group and vice versa. Thank you.
I would second that. I think it makes a lot of sense to have this technical group. As long as we're going to get in another deliverable around what that primary care advisory group is and making sure that they are having an input on policy and rules is a really important part of that.
So seeing no other comments, seems like we may have a path forward on deliverable number 1. I'm seeing head nods. Thank you. And so I've taken some notes on some of the other changes that on the neutral language around physician noted. We'll make those changes. We'll make the changes that I've kind of outlaid live for you here. We will make those edits, circulate this all to you, provide you an opportunity just to make sure that you can give us any feedback. But otherwise, if I hear nothing from you, we'll post this and say this is deliverable number 1. You can see my nice green check mark.
Deadline on that feedback, perhaps, to help you?
We'll send it in an email and ask for it quickly. Thank you. Great conversation.
Thank you.
Okay, I do want to make sure that we have a full hour for our discussion time. So I'm going to bring up this topic of the primary care spending target and maybe get some initial reactions from this group. just to, as a kind of a temperature check, and understand that there'll be obviously more conversation to come on this. So first, I just wanted to acknowledge, as I just did, how I think that the next three deliverables do largely fit together. And I would suggest that while there's different dates attached to each of these, my suggestion would be that we try to get as much consensus as we can before the end of the calendar year on a proposal. I think there is continues to be a lot of urgency on this issue. The legislative session is, moving quickly, and an opportunity for legislation in the new year is upon us. And so let's keep at this. This is going to be the hard work ahead of us. But let's stay at this, and I hope we can continue to build consensus on these next three. So want to spend a bit of time on the primary care spending target for about 10-15. So as we heard from Chris Kohler, the primary care spending target is a feature that many states have pursued. It is at its heart intended to be this measurable target for rebalancing what we know is an underinvestment in primary care in the United States. And many states have pursued this as a way to be able to track progress over time. And some states have gone even further in being able to use this to have accountability for different provider organizations or health plans to make sure that they are, incrementally over time increasing the share of healthcare spending on primary care. This has also been a feature of many of the legislative proposals that are currently before us in Massachusetts. And as you can see here, the three bills that are kind of the main primary care bills, all have this as one of their primary features. I would say, part of this is that the targets in of themselves, are a way and a tool to try to change and rebalance the healthcare system. But there are also, this is connected to the payment reform change. It's connected to the care delivery design change. All these pieces fit together. But nonetheless, it does send a bold message as a state to say, this is what we're working towards, and we're all working towards this together. In many ways, I do think of it kind of like the benchmark. It's a symbol about saying, this is our values, this is what we care about, and this is what we're working towards. So as you can see here, there are different dates and different targets among these three bills, but they all are relatively between 12 and 15%, and all kind of by the end of the decade. The 12 and 15% is also very consistent with all of the other states that have these types of spending targets. And why is it 12 to 15%? The logic behind the 12 to 15% is largely a reflection of when states have looked at other high-income countries that have invested in primary care and how much of a proportion of their medical spending is in primary care. So when that is really kind of the logic, if you look at other countries, it's about 15% of their expenditures on primary care. So that's why states have tended to pick 12 to 15%. So I just want to show, this is a little bit of our baseline in terms of what SHIA has reported, a proportion of spend in the commercial, Mass Health, and Medicare, around 7% commercial, a little bit higher in Mass Health, and a little bit lower in Medicare. So I wanted to put forward kind of a straw man proposal to this group to get some initial reactions on a potential approach. We heard from Chris Kohler that his recommendation is to do incremental improvement. The idea of saying, let's have an annual improvement because not everyone is going to be starting from the same place. And we also know that there are some states that have really done this kind of aspirational target, kind of into the future. So what I would suggest for discussion is an approach that combines the two ideas. That includes an annual improvement target of a 1 percentage point increase in the share of primary care spending as a share of total medical spending each year for the next 8 years. combined with that aspirational target of getting to 15% of total medical spending allocated to primary care by 2034. We would be using 2026 as a primary care spend as the baseline. That we would agree that there should be some measurement and accountability for health plans, and health systems, and managing clinician organizations. I think we would need to think more about what we mean by that, but as a principle. And also as a principle that increasing primary care spend over time would not be increasing the growth into overall total healthcare expenditures. And so just as a visual, this is what this would be, an 8-year trajectory of going from 7% to 15% in the Commonwealth with that 1% annual growth each year improvement target. Dr. Altman.
This is an amazing start to this conversation, and I think we're almost there. I would say an 8-year ramp is way too long. I see the struggle with primary care, and the struggle is the patient's struggle, not our struggle. And the struggle with primary care is like a tug of war, and the Massachusetts State Legislature just put 25 people on our side of the rope to try and help with this tug of war to fix primary care, except we keep losing. Even though there's 25 more of us on the rope, we're going backwards. And we don't have 8 years. Our patients don't have 8 years to wait to fix this. So I think a reasonable compromise to this straw proposal is 2% a year over 4 years, moving 2% at a time over 4 years would be a reasonable compromise to achieve that. The one other point I would make is I'm reminded of something that Mark Friedberg said at a previous meeting that I thought was a really important point. And that is that you can have this goal for 15% and getting there over such and such time, but you can definition your way to 15%. Not that we would. I think we have a solid definition, and I so trust Chia with that definition. But there are different people come along, and you can do things that, and so Mark made the point, if I'm getting him right, is that we should think about doubling primary care spend.
Yeah.
And then you concluded, David, after he said that maybe we need to do both. And I thought you both were right about that.
Thank you. Thank you, Dr. Altman. I'll go this way and then I'll come back this way. Dr. Black.
Just curious if that 1% is tied to any sort of an inflationary index, or is it just a flat 1% to 2% over time?
It was just a 1% increase in the share of primary care spend as a share of total medical expenditures. So as a matter of how much that actually calculates into increase in primary care spend, I think we've done some rough math, and I'm looking at David Auerbach, about 10% a year. Correct, David?
Yeah, a little more.
A little more. It kind of estimating what we think total healthcare expenditure growth is and how much you would need to make progress. Okay.
So as the pediatrician in the room, I'll just say the phrase we always say is children are not little adults.
Yeah.
Percent spend on pediatric primary care is actually traditionally a little bit higher because they don't cost that much money, right? They're not hospitalized that much. So what we would recommend instead of, for pediatric portion, I know it's complicated, but taking instead of that 12 to 15% target, but having a percent increase, which I know there's a difference, and I know we want to sort of do everything together, but I think we need to really realize that pediatrics is a different population when it comes to primary care, and we're preventing, things 20 years from now. And I think, Mass Health has worked on this a lot, but just please keep that in mind.
Yeah, no, thank you. I really appreciate you bringing this up because I wanted to have a little bit of this conversation. Maybe we'll need to bring it up at the next meeting. But I know at least California considered having separate targets for the pediatric and adult populations. Ultimately, they did decide to kind of, aggregate together. So I do think we should have that conversation. I think at a minimum, and as we just discussed with Chia, we'll be able to disaggregate and track separately. But I think when setting improvement targets, we should talk a little bit more about this. I'm going to do Dr. Gilchrist, and then I'm going to come back around this way.
Excellent. So one, I'll second Wayne's comments. I think 8 years is way too long. 4 years, 2% makes a lot more sense. And patients need, to see that improvement sooner. I also want to just make a comment about the high income comparison in other countries, right? I think they also often have much stronger public health kind of measures. And so I'm glad we didn't go with 12%, and 15% is definitely more palatable. And so we need to consider that often primary care is delivering where we are falling short from a public health measure. And then my last one's a comment's a question. How does pharmacy spend work into that as I think about total cost of healthcare? And like that seems obviously a growing portion of healthcare spend. I just don't know how that works into those circles. Assume it's in the bucket.
Yeah, I think for this particular exercise, and that's something that I wanted to ask too, is like, what do you want in terms of additional modeling and additional data would be helpful? I think for this particular model, we kind of were roughly trying to kind of figure out the bubbles, so to speak. I think we had pharmacy included. I'm gonna go down this way. Dr. Friedberg and Renee.
Yeah, thank you. Wayne, you had it right in terms of my previous comments. And I'll just go a little bit further on those, especially building on something Dr. Gilchrist and Dr. Pring mentioned. Stratification is going to be really important here because any fixed target, no matter how you define primary care spending, sort of within reasonable bounds, is going to have really different effects on different age stratifications, even within a pediatric population. You get down to like really young kids, like a ton of their spending is in primary care. Just statistically, they are in there a lot for well child visits, almost like on a monthly basis for a while. But that age is not the only one that really matters. It's also comorbidities, and sort of counterintuitively, people who are more medically complex, just all other things equal, have much lower percent primary care spending. So we also have to think about that, because we don't want to ever create an implicit, unintended incentive to avoid that kind of a population in an effort to do better on a primary care spending target. These are the kinds of things like technical advisors can help a lot with. I worry a lot about just setting a numeric target of 15% without first pre-specifying a fixed definition of primary care spending. That could be the current CHIA definition, or it could be the next one. And there are a couple things I think to consider in the current CHIA definition. We've talked a little bit about, sort of obstetrics and sort of that role in there, but also right now the CHIA definition specifically excludes any mental health care provided in the primary care setting. So there's a PCP if I'm taking care of depression, which I did all the time, that would actually not count as primary care spending under the current definition. That seems like something to reconsider before setting a numerical target. And you'd want to sort of see where on a fixed definition, that future fixed numerical target, what kind of a multiplication that represents. Now, but I love the idea of going between now and then on a percentage basis, because that will accommodate changes in the CHIA definition of primary care over time. Because you have to, you can back calculate that reference here every single time you change the definition. But that one piece I worry about being in statute, that 15%, maybe that'll look more or less attractive once we update the CHIA definition and say, okay, that's the definition against which we are going to set that 15% benchmark.
Yeah, thank you, Dr. Friedberg. I had I think another idea, and not to float this live, but 2026 will be our baseline. We'll know what that number is. And we could say something in statute to be like double that, whatever that number is, or 15, whichever is greater, or at least 15 or double,
Or minimum of both.
minimum, right?
Floor for both.
So there's something there. Renee?
So, Dr. Friedberg, very good points. What I want to put in here though is however incrementally we increase this investment in primary care, I think it would be more powerful if that was coincident with changing the way the money is delivered to the clinics.
Yeah.
Or I hate to break it to you guys, not only am I CMO now, but I'm doing an MBA and I've been reading some stuff. And really it is about, if we can immediately change the margins of operations for these clinics, that would be like investing money immediately. We could do 1% a year, if I could stop paying an accountant 6% of my revenue to do billing. If that could even be cut down to 4% by doing a PMPM, by doing a multi-payer single fund that I just send in a list. I've got your panels. We're in a situation where it is about the margins. I don't really care how long it takes to increase this. I really care if next year I can immediately impact my margin. And that is about me decreasing the expenses. Quick story, there's a guy who ran all of Japan's pension funds for the government. And he had so much money because he's running all the government pension funds. He looked at the market and he said, I'm not about investing in one company or another. I actually want the entire market to do better. I am so big. That is what we have to think about when we think about a multi-payer in a single fund. That single fund wants all of primary care to do better. The insurance companies, they'll pay the same amount of money in. But the fact is, I, as a CMO, will not be operating in the red if I don't have to send all my money to do billing. And that can happen in a year. And you can slowly increase things over time. We need all of this to get better in a way that allows us to do this simpler. We have to change the system, because I'll tell you this, one of the other things everyone's talking about is how are we going to make sure these health systems are getting the money to primary care? You make it so easy to open up your own primary care practice that guess what? MGB is going to be like, you know what? I'm going to do a better job with my primary care folks, because if I don't, they're going to go work for themselves and with their buddies. So that's what we have to look at. Simplify the structures so that we can incrementally increase things. But if we simplify the structures, boom, 4% margin change in a year.
So I have a couple of comments. It's not just to add on to what Renee's talking about. It's not just the billing, but there are many things that are administratively burdensome that practices spend money on that are completely unnecessary, and that we really need to make a detailed look and decrease the administrative burden so more money is actually spent dealing with patients and getting them the right care at the right time at the right place, as they say. But I also think one of the things we have to be aware of is that the goal is to not increase the growth of overall expenditures. And I can tell you, as a, primary care doctor who's been in the business for a very long time with a very big practice, there are short-term things that with more resources, I can change. I can easily help decrease readmissions. I can easily help decrease emergency room use that will see an immediate change in expenditures. But the bigger value is that if I keep my patients' diabetes under control, their heart failure under control, etc., the long-term benefit, if I prevent their colon cancer in 5 years, the long-term benefits of savings we won't see for years. And so we have to make it ourselves aware and others that there's going to be a short-term benefit that will be much lower than the long-term benefit. And the health plans may or may not care about that. Medicare certainly cares about that. Mass Health certainly cares about that, because they typically have patients for very long periods of time. But I, as a primary care doctor, and we as a state, need to care about that as well. Thank you.
Barbara?
Okay, thank you. So just to give some perspective about a 1% increase, if we were to go by incremental, since CHIA and MHPP have been putting out the dashboard, the primary care spend has gone down a full percentage point for commercial spend and for Medicare Advantage.
Wow.
So we're not talking about level and then going up, we're catching up. And so if you do double it, that's directionally that much more difficult, particularly in this difficult financial environment where healthcare is being completely under attack. And I think to Barbara's point, Massachusetts has a great track record. We were voted #1 in the nation by the Commonwealth Performance Report of looking at all the states. However, when you look at what we're worst at, We're worst at unnecessary hospitalizations. We're worst at unnecessary ED visits. We're worst at primary care spend. So that is not sustainable. So this is really putting us in a place where we really have to think about how we deliver care differently as a state and where we want to invest our money. I think the point about transparency that Renee raised is really important, and we've talked about that many times, that if you set a target and all the money goes to hospital-based practices, but it doesn't make it down to the practices, there's a problem. In fact, I heard a colleague from Delaware talking about they had a primary care spend for the insurers, and the insurers hadn't spent enough, and so they ended up paying the hospital more money because the hospitals owned the practices and they hadn't paid primary care. So it just comes out in a way you wouldn't expect and wouldn't want. Finally, I just want to quote my colleague Asaf Batan, who's a primary care clinician and runs the Ariadne Labs. He's been talking about a triple double in primary care. He's a basketball fan. And so one thing that he'd like everybody in the country to think about is doubling primary care spend, doubling the number of clinicians that end up practicing in primary care after 6 years after graduate school, and doubling the number of patients who receive care from community health centers. So Massachusetts might want to think about that as we think about what we're planning.
All right, Christina, John, or Judith, and then I'll end with you.
It was a nice point in the meeting to give what Mass Health has done another shout out, because they've managed to figure out in slide 17, right, getting primary care spend up, measuring and holding the entities who are engaged in that work, health plans, health systems, provider organizations accountable to how that system works, defining primary care, coming up with a lot of specificity on how that money specifically has to get to primary care practices, holding primary care practices accountable for an enhanced model of care, and doing all of that without driving growth in healthcare expenditures. Colleagues from Mass Health can probably speak with more specificity. I think that the cost growth curve in our Mass Health program has been less than the cost growth curve in Massachusetts outside of the Mass Health program. So as we move through this work, it's great to look at out of states. It's great to bring in speakers and learn from them. I feel that Mass Health and what Mass Health has done is like the most powerful thing we can learn from, and the most powerful thing that we can replicate without having to make this stuff up in terms of some of these really sticky issues that you have on this slide. Like, how do we increase primary care spending without increasing the growth in overall healthcare expenditures? I think they've nailed it. And then lastly, just a point of clarity, Mark, I wasn't sure your points were about sort of lack of clarity from CHIA. I think when we were talking about, and it sounded like reaching consensus around deliverable number 1, that there was endorsement in using CHIA as the source of truth, if you will, for the definition of primary care, what's included in primary care at all. So it's just, that was a point of clarity I was looking to leadership for.
I think I'll let Mark speak for himself.
Yeah, definitely not trying to undermine deliverable 1's assignment of ultimate spending definition, deciding from CHIA, like that should come from CHIA. I just know that definition, can change over time and might change in a couple ways I outlined.
Oh, okay, so it might change, but not that they don't have it.
Right.
Thank you. Helpful.
All right, John, Dr. Mellon, and then I'm going to get,
Yep.
Thank
you, David. I appreciate the last bullet. I'm just having, we can't increase expenditures. I'm just having a hard time envisioning how that's going to happen when we have a benchmark that's been totally flaunted and ignored, for years now. And the other day I went back to the occasion. I would recommend everyone do it. Go back and read the Globe Spotlight series from 2007 that detailed the so-called golden handshake, and it looked at the years 2000 through the passage of the chapter 58 20 years ago. And it talked about how in the year 2000, Partners was acquiring massive amounts of primary care practices 25 years ago. And I just wonder, just saying something, this is the way it's going to be, is it really going to happen unless we knew that was going to be a problem? We did nothing to stop it. And would we even be sitting here today had someone stopped that from happening? I just throw that out there. We keep talking about costs and we have for the last 2 decades, but it's just important not to create another free pass for certain parts of the healthcare industry just to raise it another % per year.
Thank you. Dr. Mellon? I'll do Dr. Mellon, Suzanne, Senator, and then we're going to move to the open discussion.
Perfect, thank you. How about that?
Yes.
Yeah, there you go. Okay, thank you. I'm so glad to hear that seems like, at least everyone I've heard, is in favor of moving with alacrity, more alacrity towards the solution on the this piece related to allocation of financial resources. And I'm not surprised that everybody in this room would say, yeah, that's good, that's great, fantastic. I am concerned that much of the rest of the state might say, wait, why, right? So I wanted to point out a couple of the 3 of the key talking points that I think will be very important for our physician colleagues, for our advanced practitioner colleagues, for the rest of the public. The clinicians are a very hot commodity, and the borders of the state are very porous. This is a great thing to live in a place where we can go where we want to, but it's an issue when everybody else wants us as much as Massachusetts wants us. People that I have no idea how they found my number are now texting me to offer, you could start this day, that day, this day. And those people, rarely are those people from Massachusetts, sometimes, but often they're from other states. And I'm certainly not alone in this. This is just, practicing bread and butter primary care. There's a separate set about leadership positions. That makes more sense. But like, why would I leave now to go? But they think I would. And I'm seeing that our colleagues are doing so. And some people would say, well, if we just give them 1%, allocate 1% more to them being the clinicians, they'll work more hours in the day. But, apparently the study says we're already working 28 hours a day. I didn't say that wrong. That is, I think that number is what I'd love to try to work more than 28 hours a day. I'm a worker. Yeah, I know, but you've seen the studies,
Yes.
right? It's 28. So, but it's impossible, right? You can't work more than there are hours in the day. None of us can do that. And it takes years, lots of years, to make one of us being clinicians. We can't just flip it on a dime because now there's some more resources. I'm most familiar with medical student and physician training, so I'll use that as an example. Medical students enter with all sorts of noble goals, and some of them, far more than actually become primary care physicians, do want to become primary care physicians on the first day. And then by the 4th year, there's another thing they could do. And once they're in that training, they can't become a PCP if they've learned to be another very important kind of physician. If you're a surgeon, can't do this. So we need to capture people, keep people in the training pipeline that will allow us to replace the many people who are retiring and continue to increase the availability of us. I believe it takes fewer years. I'm sure it takes somewhat fewer years to become a nurse practitioner in primary care or a PA in primary care, but it's still measured in years, not weeks, not months, years to get to be able to treat your first patient. And so what we're doing now is informing choices that people being admitted to those schools now, you know, they just applied, right? So it's September, they just applied. We gotta have them know there's hope, real hope, you know? Thank you.
Thank you. Suzanne?
Thank you. And I appreciate everyone's comments. And I do want to just make one comment to David, as you were saying that all these deliverables and recommendations go together. And just remembering Chris Kohler's conversation about what other states done with all these deliverables. It's like, I don't know, Massachusetts is going first. And that's really important to kind of take these together. And I'm actually thinking back to at deliverable 2, which I know we're going to return to, and how important that is when we're talking about the enforcement mechanism and following the money. What data and reporting can we get from carriers and health systems that we don't have now, that we really need to understand following the money to the practice level, given that many primary care providers are in big health systems. I do want to agree with overall, this framework is fantastic. And I think this is the framework that it seems like folks are agreeing that we should work with. I think a phase-in is important. I would like to see it a little faster, but so I would love to have continue that conversation about what we think might be feasible across, you know, health systems, carriers, et cetera. I would be remiss also, because I work on children's health at Healthcare for All, if I did not echo a lot of my the comments about pediatrics and how do we fit that both that we recognize the difference in pediatrics, but keeping kind of the system simple. And I don't know what the answer is to that, but I just wanted to mention that. And also, as we did with deliverable 1, that we do have an infrastructure in this state. So utilizing the HPC cost benchmark infrastructure, I think would be really important in thinking about enforcing the spending target. And you know, although we know that you would want to go harder on some things within the HPC, there is an amount of flexibility there too. So as we're kind of trying this out, we can kind of be a little flexible if there are different circumstances as to why the spending is not where it should be, and try to work with carriers and health systems to change that. So not you know, some sort of maybe performance improvement plan, but maybe not that formal process at the beginning, but something like that to make sure that we're getting to the goal.
Awesome.
Thank you. So this has been really a great conversation. It's a little frustrating, and I realize it's because I've talked to every single one of you in my office, so I know exactly what, you know, when I hear this, I go, yeah, we know that. Yeah, we know that. So to the question about including pharma, I would separate pharma out very much, because it's its own entity. And the fact that you're spending more on pharmaceutical medication should not be included in, oh yeah, look, we're increasing primary care. The definition of primary care is critical. And I agree with you. I thought that our last definition, we can't continue to change that over time, because if we do, then all sorts of intended and unintended consequences will happen. Like, oh, look, now we took that out. Look, our costs, our spend has gone up. Or look, we added this, our spend has gone down. So consistency is really critical. My name was up there. I don't care about the 12% or the 15%. I'll do whatever makes sense. It is an it's an axe. It's a thing to say, damn it, here's a target, okay? And so whatever works, I think is what we should be focused on. I will say that we really need to understand where the money is right now in order to really set what it should be year by year. Because I would maintain that probably if we really understood where the money was going, maybe in the first 2 years, we could increase it by 3%, or we could increase it by 4% by saying, oh, wait a minute, it's going there? Well, no. That's not primary care. And so having that information is really critical. So I wouldn't, you know, set a hard percentage or something, because we don't know what's in that bucket yet. But in overtime by 2030 or something, yes, okay, but we that's why we need that definition so badly, and that's why we need to figure out how we get the health systems to tell us what they're really spending on primary care, because we can see it at the individual independence. We can even see what the insurers are spending, right? We know that. We see it. We see, tell us your rates, tell us, but when it gets into the health system, we're really at a loss. So I would say that that's really important. And then I would just say, thanks to my partner here, that the increasing of primary care spend over time, we really need to look at that at an entity level. We can't just say, oh, look, the system's spending, we haven't spent this much because maybe we've taken that all out of Holyoke, or maybe we've taken all out of the community health centers, or maybe, and we know who the big players are. Every single person, every single entity has to put skin in this game if we're going to solve this problem. So we really need to see that primary care spend of time without increasing the growth in overall healthcare expenditures really has to come down a couple levels so we see who's doing what. And then I just want to caution that we can't make this more complicated than it is. Okay, it is not going to be perfect. Oh, one other thing before I say that, to your point, John, we don't give HPC authority to do anything. We don't give them. We let them tell us what's going on. They tell us that everyone's going over the benchmark. And then we say, thanks for sharing. So if we really want to do something around that issue, we have to give HPC authority to make those decisions and change those numbers. Otherwise, we're just going to keep doing the same thing. And I think we really need help in putting that forward. Maybe it's not HPC. I think it should be, but if there's some other better way, fine, do it. That's great. We don't care. And then just to the point I started, we can't make this more complicated than it is. It will not be perfect. If we can get to good, we're fine. If we can start moving this needle as fast as we possibly can, we will make mistakes. Things won't be, some people will like it, some people won't, but we just have to do our best, and we have to do it with urgency and efficiency. So that's what I have to say about this. Thank you.
Well, thank you. Can we?
Sure. It's just
Thank you for the conversation. I think you've given us a lot of great tactical feedback. That's exactly what I wanted, in just putting something up on a slide and having you guys react to it. So we will come back at our next meeting, having taken that feedback with some new ideas, some modifications, and we'll continue working on this. I'm now happy to turn it over to my co-chair, Mr. Secretary, to help lead a broader discussion about our vision for primary care.
Thank you, David. Good discussions so far. I think this came out of comments where a few of you that you wanted a sort of more in the wild conversation that sort of tapped into your expertise, but also your aspirations, your ideals, what you're looking for. And so that's why we wanted to sort of have a more open-ended discussion and conversation for people to feel like that their expertise is actually getting plumbed in a constructive way. And so there are a series of questions. If we can move to the next slide. Sorry, it's the question slide. There we go. And so if you can take a look at these questions in terms of thinking about where your comments should be, and where I think it would be helpful for both those of us who are in the midst of drafting the report, but also for the public. There's a lot of interest in this, and there's a lot more people following this online, and there's a lot more people following the coverage of this. So I think questions for you as experts in primary care, like around this, like around these questions. You don't have to answer the questions like in order. You don't have to answer all the questions, but essentially try to look at this and think about how you would frame some of your most important answers on this. I particularly like the second question, but feel free to sort of go wherever you want. I didn't see Dr. Critchlow.
Thank you, Dr. Secretary Yania. Just to speak to some of this, what I will say is, number one, a big part of what we need to try to get across to the public is primary care as a system is what we're trying to change here. If people think that it's just about getting clinicians more pay, then they don't understand the problem. You could pay clinicians in this state triple. If you don't change what's happening, they will keep cutting back their hours and they will keep moving out of the state. When we look at how excellent this amazing Commonwealth is with healthcare, we also have to look at, oh, wait, what are the areas where we weren't number one? ED, unnecessary visits, hospitalization, unnecessary visits. The two most expensive things to not do well in. And both of those are directly impacted by primary care. Those two things are also the leading contribution to medical debt. Those are the things that take people's houses away. They lose their livelihood and their jobs. So when we're looking at primary care reform, we're looking at impacting the things that impact the people of this Commonwealth the most. And it's about payment reform, practice redesign, and the pipeline. And that three-legged stool is absolutely integral in making changes. And we can see the results of those by the impact on things like unnecessary ED visits, unnecessary hospitalizations. Those things take time because part of what we're looking to when we say the practice redesign part of this, that is team-based care, that is technology, and that is time. And all of those things take upfront investment. Fee-for-service does not allow that to happen. So when we look at what primary care could look like in 5 to 10 years, it is a robust system where everyone as a primary care clinician, if there's a team that takes care of them, their preventative health, mental health, acute and chronic illnesses, they know exactly where their home is, and that home knows how to care for them. But the biggest thing is we have a robust group of growing young clinicians that want to practice in Massachusetts. And we have no one losing their house because they had to go to an unnecessary hospitalization. There are big impacts from changing primary care. Pipeline, payment reform, and practice redesign.
Thank you, Dr. CMO Critchlow. And also a reminder, I'm going to try to limit you guys to 2 minutes.
That's
when you're and so we'll go with Barbara number 1, Barbara number 2, and then Michael, and then Stephen.
So I just need to add to Renee that the third thing that we spend a lot more money on than anywhere else in the country is post-acute care with very limited availability of home care. And, you know, as a older physician who takes care of a lot of older patients, I'm running a managed care organization. It is a real flaw in our system that we prefer to send people to nursing homes than we do to send them home because they can't get the care they need at home. And one of the reasons other countries spend less is that they have a much more developed home care system, much more developed public health resources that we just don't have. So I think that's the third thing, that it's not just ER and hospitalizations, it's post-acute care that we could really spend more on. Thank you.
Thank you. Barbara.
Thank you. So I love this question because in 2021, MHQP convened a task force to come up with a vision of primary care when we found out how fragile primary care was in Massachusetts. And a number of you here were at the table at that time. So I went back to 2021 and I will add a few things. First, care is team-based and we need an adequate pipeline for everyone. One thing that we haven't talked about here is that Massachusetts has a state medical school. And I believe it was chartered to improve the number of primary care docs we have in Massachusetts. But over time, it's sort of veered in a different direction. So I think whatever levers we have to help UMass churn out more primary care docs that will stay in Massachusetts, it's an important lever that we have. We should use it. Also, so there's, in terms of, I'll go into the next one after team-based. So practices have tools and resources to promote health equity. It's really important that we have, we focus on all populations, and we have incredible community health centers that do that in Massachusetts. Technology is fully leveraged to improve care and access. And we convened before AI was in the game, and it's a game changer, as many people have said. And so we really, and I'm not sure of what's happening in Massachusetts that's focusing on how AI can support primary care to reduce burnout. And a lot of it's happening in practices, but things could happen that aren't so good. So we should really focus on how AI, and also the public is pretty unaware of how much technology and AI is used in medicine and on a day-to-day basis. So I think working with patients to sort of understand that this can help primary care and get agreement that this is, yes, it's a good thing. Well, not say it's a good thing, but talk about it, talk it through, and come up with some.
10-second warning.
Oh, so much to say. Okay. I think that well, I've got, I'll have to see my my 10 seconds because I have too much to say. But thanks for the opportunity, and I can send around sort of a link to all this.
Thank you. Michael, Stephen, Mark, Suzanne.
My comment may provide the framework for folks to feed in feedback on this particular topic. I think it's a really good set of questions. I think it's important to detail the end state goals of what primary care should look like in 5 to 10 years in a documented way. We have detailed expectations, or we'll be developing detailed expectations around spending and spending targets, but they should be constructive towards the development of detailed concepts and metrics for the actual improvements in the primary care practice. So things like, as an example, the number of primary care doctors in Massachusetts, the wait time to get a primary care appointment, the items that the barbers have just mentioned, and make a concrete list. It doesn't have to be perfect. It should be the, let's call it the top 10 list in honor of David Letterman, for those who still remember David Letterman, and then track to that list maybe every 2 years, not yearly. I think that's a little too much. We are tracking spending on a yearly basis, but let's track to our top 10 list every 2 years so that we can see if we're actually moving the needle on the real things that we're trying to improve upon as the end state goal, period.
Thank you. Stephen, Mark, Suzanne.
Thanks very much, everyone. Thank you, Secretary. And I'm coming in from the rural, and actually I'm the rural designee for the committee. So just want to report in from the 70 rural towns and school districts that just had their health insurance go up 37% year over year, leading us to cut positions, including our high school librarian at Pioneer Valley. And I want to echo our superintendent, who said, quote, "No school district should have to choose between promoting literacy for students and providing healthcare for employees." And that is exactly where we are in my state of the Commonwealth. You may know the quote also that the fox knows many things, the hedgehog knows one big thing. I think the one big thing for number 2 or any number on that list is that people who are symptomatic or sick should have timely, effective help. And to quote one other person, "It is not the healthy who need a doctor, but the sick." And that person was Jesus Christ. So we've known for a long time what healthcare is about. It is about taking care of people who are sick and symptomatic. And yesterday afternoon, it's a quick example, I had a patient who was in the ER for 12 hours, left with chest pain, came to me, and likely has a pulmonary embolism with a clot. We were able to get a chest x-ray for her, blood testing, give her Lovenox, write a DOAC for her. These are all acronyms, but 2 minutes. And in the end, she, I think, will be saved from not getting a catastrophic event. She will not have to go back to the ER, which she was not going to do anyway. And in the same afternoon, a patient and a family member is starting an outpatient alcohol withdrawal, which can happen in over 80% of patients who want to quit alcohol. I don't think there's a handful of clinics in the state that would do that. So
30 seconds.
30 seconds, I'm grateful for that. I want to tell you what I'm measured on. I'm not measured on anything that improves people's health who are sick. Nothing. Last PC visit, annual physical, depression measure status, not whether people got better. Last A1C, a measurement. Last uncontrolled hypertension, I could go on about that. A risk score and a gap score was whether their health complexity was noted. None of those measure me if I helped that patient yesterday. Until that is fundamentally changed, we will rewrite each deck chairs in this Titanic, and primary care will be no different because the incentive structure is completely against helping people who really need help. Thank you.
Thank you. Mark, Suzanne, Wayne, Christina.
Thank you. Yeah, on the question about how primary care should look, ideally, I'd like to see patients pretty much everywhere in the Commonwealth just have greater access to the 4 C's of primary care. And I think you're familiar with those, but coordination, first contact, continuous, and patient-centered care from whatever source of clinical care is most suitable to the patient. And that's very measurable. We can measure that through patient surveys. We can get at some of the constructs that Dr. Martin just mentioned. I think patients are the gold standard for gathering that information, and we can do a lot more with patient-reported outcomes to measure those very important aspects of care that we're currently not measuring very well, if at all. I think for clinicians, I'd like to see the job be more doable and less burnout-inducing. I used to, when I was at RAND, I did a lot of work for the American Medical Association, going around to different parts of the country, Massachusetts, but not just Massachusetts, all over the place, talking to clinicians and leaders of provider organizations about how they received new payment models and what they did with the money, and what ultimate effects it had at the front line, including primary care and also specialty care. And it's like almost an impossible task. But one question that really served me well was, where did you get your furniture? Because you'd invariably hear from the orthopedics, oh, we got it, it's new, it's great, isn't this amazing? And then you'd go to the primary care practice, like, well, we got this great new furniture from orthopedics when they passed off their old, really heavy, inappropriate for primary care benches, which is exactly what I had in my own clinic. We couldn't move these things around without like throwing out your back with 2 medical assistants. It was a disaster because they came from orthopedics. So I want to see that question change. I want to see the answer to that question change. Then we'll know we're moving in the right direction. Another system I did some work for, a very famous, I won't name it, fully capitated system in California. So this isn't fee for service. Their managers had something they called ABC time to keep their primary care providers around. ABC stood for anything but clinic. I don't want that construct I don't want anyone who runs a health system to think they need ABC time to keep their primary care practitioners around. We can start to measure that, especially because I think ABC time is a real problem as we think about our primary care. We think we have an oversupply of primary care physicians here, but no one can get an appointment. Why is that? Probably because so many people are doing so many other things than seeing patients. We have a very part-time oriented state. Let's actually get our arms around that with rigorous data collection, possibly through the Board of Registration in Medicine. It's an easy survey to do every couple of years. Board doesn't ask for much. Maybe ask some questions about how you spend your time. We see that move in a more clinic-intensive direction.
Thank you. Suzanne, Wayne, Laura, Christina, John.
Okay, thank you. I'm going to go from the 10,000-foot view and go back to the principles that we look at Healthcare for All, which is access, equity, and affordability. And thinking of affordability both at the systemic level and at the individual and family level. And one of the things we hear often on our helpline with regards to equity is language access. So I do want to just mention that because it is something huge. 60 to 70% of our calls are from people with limited English proficiency. So that's really important to our organization as far as equity and access is concerned. And I just want to, say one of the things that I've been thinking about too is just generally, how do we support primary care providers or clinicians or teams to support patients? So I think these are just like some principles I've been thinking about when we're thinking about what is our system look like. And part of that I've been learning about is about team-based care. And are there other folks that, can take some of the load off of the primary care clinicians, folks like community health workers, integrated behavioral health clinicians, other folks like that. who we can build these teams and who build longitudinal relationships with patients as well. And last, I will say that's been brought up a lot of times before is the administrative burden piece and how do we both measure and see what we want to see, but also reducing that, which will also reduce the load on providers so they can do what they're meant to do, which is to help patients.
Thank you, Suzanne. Wayne, Laura, Christina, then John, and then if we have time, David.
So I've really enjoyed this almost 2-hour oasis from conversations about what's happening in Washington. And I'm really struck, I'm just grateful to all of you. I'm really struck by how much consensus and agreement there is around this table and how much shared values there are around this table. We all have some different ideas, but I think we're mostly on the same page here. And it's really nice to see in Massachusetts that we are able to really work really hard to make people's lives better and to help people who are sick and suffering, as Dr. Martin pointed out, as a core value of what we're about. And I think with those shared values, I think we all know what we need. I think we've articulated what we need. And I love that we've been having such robust conversations about how do we get there? What do we need to do to get there? And I believe Albert Einstein was quoted a few minutes ago. If we want something different, we have to do something different. We have to behave in a fundamentally different way. We can't just be putting Band-Aids on our dying system in primary care. And I think that we need to take a hard look as we move forward with this task force at the concept that Dr. Critchlow mentioned earlier, which is the idea of having a separate primary care fund that pays primary care, that allows us to adopt the same principle that the Japanese pension manager was using.
30 seconds.
Was how do we make everything better? How do we make it better for all our patients? And I think we're going to know that we've got there when a larger percentage of patients say, I have my own personal primary care clinician. And I think we'll know we've gotten there when not only is the cost benchmark respected, it is reduced.
Thank you, Wayne. With 2 seconds to spare, Laura.
So I think ideally in the next 5 to 10 years, we'd like to see that everyone has access to primary care providers and they're able to access timely appointments. I think ultimately we'd like to see BH integrated into the primary care practices. I think that would really help with folks who go untreated and have a bifurcated healthcare system when it comes to BH. I think we need to leverage technology and AI for clinical reasons and obviously for administrative simplification. And the plans, are working with that right now on some of those efforts through the Mass Health Data Consortium. And I think we see success if we're able to bend the cost trend, meet the benchmark, improve quality, reduce ER visits, and some of the measures that we've talked about, hospital admissions. Those will be the data points I think that will tell us we've been successful.
Thank you, Laura. Christina.
So aspirationally, I'd like to see single payer for primary care that has full prospective population-based payment. As much as we can reform primary care, I think we cannot ignore that the system also needs to be reformed so that a high-performing primary care practice is still not obligated to send a patient for an inpatient admission in order to get the requisite outpatient testing that a primary care provider thinks that they need. And really also holding primary care accountable for truly understanding what patients need licensed level of care, which patients don't. I think we'd like to focus on primary care provider shortages. I'm not saying that that is not true, but I think we also have an opportunity to really look at that and right-size supply and demand, as other countries have done, to make really informed decisions from a patient perspective about who can best serve the needs of the patient. Is that non-licensed, licensed, NP, PA?
Thank you, Christina. And we'll go to John.
Yes, thank you. There we go. Excuse my lack of knowledge about this, but I look at this like I do with my membership, primarily small businesses and their workforce. It seems like what isn't listed there is pipeline. And I just wonder whether the med schools are doing what they need to do as far as that first and second year student to really educate them on what the pipelines are, what the opportunities are. I know I can only speak to it from the perspective of my own son. I have a son, as I told David earlier, who's an anesthesiologist down in New York City. He chose that specialty for two reasons. One was pay, obviously. Hopefully we can deal with that going forward. But the other is lifestyle. You know, after he pays his dues, you know, in the early years, he's going to be Monday through Friday primarily, you know, and that was important to him. And I've got to think that that's important to a whole lot of med students if, you know, if we can educate them, get at them early, appeal to the more entrepreneurial of those med students that maybe want to go out and set up a small business, you know, create a new primary care practice. I guess in an ideal world, I would love to see more, not less, but more primary care actual offices around, not necessarily owned by the local hospital. And I think that's better care and it's more cost-effective care. So if we can look at getting to the med schools, I think that might be helpful.
Thank you, John. Chair Friedman is exercising convener privilege. No, there's three other people that would be speaking also.
So I think my vision is that every single person in the Commonwealth goes to a community health center for primary care, and then our hospitals become true tertiary stages, places to be. But that's definitely. I think this is very specific because I actually agree with pretty much everything I have heard, and I think all of those things. I think in my view of the world, we really define primary care, we address the needs of primary care, and we separate it out. We insure it differently, we measure it differently, and so it doesn't become part of the bundle of healthcare and the way we fund, you know, insurers paying health systems, so that we can have independent primary care and we can watch very, very closely where our money is going. And I think that separating out is at this point, once we have a very strong understanding and foundation of what this should look like, I think over the next 5 to 10 years, that would really help us.
Thank you, Chair Friedman. I apologize to David, Brenda, and Laura, but we'll have to go to David. You have time? Okay, so we're changing the rules for you, David. You get one minute.
Yeah, it's fine.
Go.
So just to add, I think access is key here, right? Like the future state has to be better access to primary care, which addresses a lot of the issues that all of you have brought up. So I'm not going to harp on that. But once we know we have access, like it has to be more affordable, right? And I would even go further, whether it's single payer or whatever, like ideally primary care doesn't have copays, doesn't have added costs, that is the place that I can go and know that I can get care and that is accessible to me as a patient, which I know will lower ER visits and lower inpatient admissions and other costs as well. So I think that needs to be part of that aspirational goal is how do we move to a system where primary care is a covered service, fully covered?
Thank you, David. Brenda?
All right, I'm already a fast talker, so I apologize if you can't understand me. Just to reiterate, the system has been broken. We're number 45 in a state that's number 1 in healthcare. So I commend our group for trying to fix that and filling in other gaps, I would say, for the things that have been happening in Washington that sadly I hope are not going to be happening in 5 to 10 years. Primary care really really needs to be the medical home. And we talk about those 4 C's. And so I really look at, what can we do as a group so that there aren't all these other national businesses and apps sending me messages or trying to get into Massachusetts to deliver primary care in not even in a random way. It's not actually doing those 4 C's. There's no continuity of care. And I really am nervous that could happen if we don't as a task force and as a Commonwealth fix what's going on now. Last I'll say is that just our Academy of Pediatrics is working on a system to try to get more of our trainees, our residents that are in pediatrics to go into primary care. So it's already been partially selected after the medical school route. We could get down to the medical school here as well. Thank you.
Thank you. And Laura, you almost get the last word. I feel bad for Barbara Rapson. So after Laura, we'll have Barbara finish some of her list for 1 minute. So go ahead.
Just very quickly, as an NP who's on the cusp of owning an independent primary care practice servicing 2,000 individuals in the rural part of the state, I was tempted to pick up some waiting room furniture from the side of the road. Yesterday, I couldn't fit it in my car because that was basically the only way I'm going to be able to even afford new furniture. We're talking about margins and being in a place where we can have financial sustainability. I'd be curious to know, John, how many small independent primary care practices are able to afford to provide health insurance for their staff?
Thank you, Laura. And so Barbara, you get the last word, and then we move to David Seltz.
Okay, thank you. So I'm just going to tell a story about myself. I had a primary care clinician for 29 years. Phenomenal relationship. During COVID, she got sick, left. All her patients went to another clinician who has a panel of 5,000. And so I'm now on a panel with 5,000 patients. And I get access, but I don't necessarily see a doctor. I don't necessarily have any continuity. And that has to change. This is Massachusetts. We can do better.
Dr. Mellon?
I'll talk very fast and eliminate most of the things that I intended to say. There's a point I haven't heard yet, though, which is what we as a state considered to be in scope for a primary care clinician. To use an example from about a week and a half ago, and I bet everybody who actually practices medicine knows exactly what I'm going to say. And that is, where do you get the COVID vaccine? And how come X pharmacy and Y pharmacy aren't giving it? There are a lot of people who know the answer to that. I don't have a special lock on the information. People were asking for free, right? Through the portal or a telephone call, not during a visit. You have to tell me, you didn't answer me. Well, it was all over the Boston Globe now for 2 days that the governor of the state legislature took positive actions to make that better. Well, I called X Pharmacy and it's not posted on their site yet. I'm really sorry, X Pharmacy didn't post it on their site yet. If I could, to stop these calls, I would go and do it for them, but I can't.
30
So
seconds.
really, what are we doing here? Another poignant examples, I think, is that there's a federal law that an orthotic for a patient with diabetes cannot be prescribed, cannot be authorized by a podiatrist. That's a whole doctorate, podiatrist. They know a lot more about feet than I do. But if I will attest that I read their note about the patient when they prescribed the appropriate orthotic, then the patient can have the orthotic covered by their insurance. It doesn't seem to be a particular insurance, all insurances. Really? Is that what we want me doing with my time? I can do it. I can read, I don't understand the terminology, frankly, but I can read it, what the podiatrist wrote, and say, yeah, you should continue. And having some comfort that telehealth will continue to be available for us to provide. So I said, I don't know. Patient says, can I see you in a year by telehealth? I don't know. I don't know yet. I hope so. Thank you.
Thank you. Thank you, everyone. I'm turning over to my co-chair with a stentorian voice to close us out.
Thank you, Mr. Secretary. Thank you, members of the Primary Care Task Force, for a really great meeting today. Wonderful discussion. Thank you for sharing your thoughts in this last part of the meeting of this discussion. I will just share that we have 2 scheduled meetings coming up, one in October, which we are planning to have virtually, One in December, location TBD. Although I will suggest that I do like this opportunity to have a meeting in person. Might suggest that we have that final meeting of the year in person. There's going to be a lot of work in between these meetings. You'll expect to hear from us. As always, if you have additional comments, feedback about the work of the task force, please feel free to reach out to me, reach out to Kelsey, and Millie, on behalf of both co-chairs. Thank you for your service.